So the objective is going to talk about the role of trauma and PTSD, describe the outcomes and limitations of the recent phase 2 and 3 studies of psychedelics for trauma and addiction, identify the elements of psychedelic assisted therapy protocols, including positive set and setting, preparation, medicated sessions, and integration sessions, and describe the hypothesized mechanisms of MDMA assisted and psychedelic assisted therapies for trauma and addiction. So one question, that comes up sometimes is why am I, as a family physician who's interested in addiction medicine, interested in using Schedule I psychedelic compounds for trauma and addiction? The background a little bit is I've cared for pregnant and postpartum women as well as their babies at UNM. I've been the medical director of Milagro since 2011. We care for about 150 women a year with opioid or substance use disorders, have about 200 babies a year with neonatal opioid withdrawal syndrome. We have a model program. We think we're very happy with our program. But the reality is that prior to the pandemic, even a high proportion of women in remission for opioid use disorder at the time of birth wound up relapsing. And so that got me interested in why do we have such a high resumption of use rate. So why is that happening? We think that a lot of it, our hypothesis is that what we're doing is we're treating the addiction, but we're not treating the underlying trauma. And there's a high incidence of childhood sexual and physical abuse and other adverse childhood events. Postpartum is a high risk time for relapse. And the presence of both PTSD and postpartum depression are additional risk factors for relapse. So trauma and addiction are really intricately linked in here. This is sort of a quote here. And I don't think I'll read the whole quote here, but just a little bit from Gabor Mate, which is that not all addictions are rooted in abuse or trauma, but they all can be traced back to painful experience. At the center of all addictive behaviors, there is often a wound. And the wound may not be as deep in some situations, but it's almost always there. And so really what we're looking at with some of the psychedelic therapies, particularly with MDMA, is to treat the wound as a way of treating the substance use. Just to put this in context here, and I really like the title of this symposium dealing with the situation of what we're dealing with right now, which is epidemics of despair, cycles of trauma, adverse childhood experiences, the veterans from the wars, the suicide, the opioid epidemic. These are all really sort of mixing in with each other to have increasing rates of death from disease and despair, high overdose death rates. So that's why a lot of us think that there is a potential for psychedelic assisted therapies to help numerous areas of mental health, including PTSD, addiction, and depression. So we're also, as this is going on, we're having a different understanding of trauma. The understanding of trauma has changed in the last 15 years or so. We've understand that trauma happens in a lot of different ways. Often it comes from adverse childhood events, but it can also happen in things like structural and implicit racism, historical trauma, intergenerational trauma, and more of a somatic understanding of trauma. This book by Dr. Bessel van der Kolk, a lot of people are familiar with now, which is The Body Keeps the Score. And this really addresses how the PTSD can be rooted in the body. I just always like to bring this picture up here. It's from one of the community groups that we work with, which always reminds me that the people that we're working with, these are not statistics just that I'm presenting here, that each person we're talking about is in my work is a pregnant person who has an extended family and children, and really what we're trying to do is going to affect all of them. So I'm going to start out with somebody that has lived experience here. This is someone who's been nice enough to volunteer to speak. She has a lived experience of addiction, homelessness, domestic violence, and psychedelic therapy. She's done work with ayahuasca. This person is actually from England. So I'm going to play a little video of Carly here.
Hi, Carly. Good morning. Thanks for being here with us. I really appreciate your taking the time to share some of your story with us right now.
Oh, my pleasure. My pleasure. I first interacted with my addictions probably from about the age of 16. from tobacco to alcohol to marijuana to cocaine, ecstasy, and then into heroin and crack cocaine by the time I was in my 20s. I'd say it was pretty all-consuming until I had my daughter. I fell pregnant with my daughter, which kind of forced me into some kind of sobriety. Before then, there was just a lot of pain and a lot of high.
Larry, I think you are muted. Accidentally, maybe. Okay, we're good.
My body as well. Feeling safe in my body. I never felt safe before. I never felt safe in situations. I never felt safe in my body. I never trusted anyone or anything. I never trusted in life. I could never be present, I don't think either. I think I was in so much pain that I didn't know, I just didn't know how to be present. And psychedelics have really helped me be with what is, no matter how painful that might be. And obviously it's helpful, isn't it, to be present? Yeah, my whole life has changed, including my nervous system, I think. I feel like I've got a brand new nervous system. It's nice and clean.
You had your psychedelic sessions. I know you had some preparation and other therapy going on during that time, and ways of integrating it. Can you share that with us?
Yeah, so I have been working with psychedelics, so ayahuasca and psilocybin now for around 6 years, and I didn't actually have any access to therapy in the formative, the first years of working with psychedelics, and I just had to go on, I guess the psychedelics were my mentors, and they told me what to look at next and what to work on, and started just working with my gut and my intuition and my own inner sort of healing system. But just over a year ago now, I'm very fortunate to have a very wonderful IFS therapist. So that's internal family systems. It's been a very hard year, actually. Probably one of the most painful years for a really long time. But I'm also can sit very proud with that too. I feel very grateful too to be able to have a body now and a spirit that can hold that level of pain from various traumas throughout my life, and hold it and love it and work with it. And I trust my therapist as much as I trust the medicine, which is saying a lot, right? Because it's like essentially putting my mental health in the hands of someone else, something else, holding space for me.
Where are you in life now?
So this year I graduated as a transpersonal coach. I co-facilitate retreats, legal psilocybin retreats for clinicians in Holland, and I work as a psychedelic integration therapist. I'm a mother. First and foremost, I am a mother. My daughter's 8 now, and we have a wonderful, joyous relationship. And psychedelics have also given me that as well, like the ability to be a good mother, you know, a caring, loving, aware mother to my child, which I don't think would have been so possible before.
Carly, thanks for sharing. We'll let you get back to your daughter. I hear her there in the background, so I'll let you get back with her. But it's been great having you talk today. Appreciate it.
You're so welcome. Thank you.
Hi, Carly.
So I wanted to share that video clip just so we keep remembering, you know, that there's people behind all of these experiences. As I talk about MDMA and psilocybin, I'll be showing a couple of short video clips there as well, so you get an idea like what the psychedelic therapies feel like from the perspective of the patient. So as far as psychedelic compounds for trauma and addiction, MDMA is really the one that's being studied for PTSD, and one that we hope to be, we'll be starting with soon here at UNM. For the classic psychedelic, psilocybin is a prototype. Ketamine has been described as more of a dissociative agent there, but it's been used for addiction, PTSD, and depression. Actually has a lot of potential in that it seems to work across multiple categories of addiction. So there's a rapidly changing landscape regarding the acceptance of psychedelic therapies. The FDA has granted breakthrough status to MDMA for PTSD, psilocybin for depression. Not sure if people talked earlier today about the NIH conference that happened in January, but it was really a groundbreaking. This was focused on psychedelics as therapeutics. About half of the presentations actually dealt with addiction, so safety and efficacy of MDMA for PTSD, psilocybin and smoking, and ketamine-assisted psychotherapy for alcohol use. So we're really actually hoping that there'll be much increased NIDA support for this work in the future. So MDMA, just to give a little summary, MDMA is been known as the drug ecstasy. I really always try to let people know really what's sold on the street is ecstasy. We have no idea what it is. When people have done studies, it tends to have a mixture of stimulants and other drugs. But MDMA itself is a derivative of amphetamine, been called an empathogen or entactogen in that it can increase self-awareness and empathy. It was synthesized all the way back in 1912 and then started being used by psychotherapists from 1976 to 1985, which point in time it became a Schedule I drug. It took from that point in time almost 20 years to be able to start doing studies on it for the therapy. That people were doing that before it became Schedule I drug. So the first study for PTSD was in 2010. There were 6 phase 2 studies from 2013 to 2019. Those pooled studies showed 82% clinically significant symptom improvement, 56% of the participants no longer meeting the criteria for PTSD. These are all studies that are happening with a control group. I will talk a little bit later about the difficulties of actually having control groups and having blinded studies. The long-term follow-up that occurred from these at 12 months showed that actually the outcomes continued to improve when you went out to 12 months, and 67% no longer met the PTSD criteria. Here's another way of just looking at what that looks like visually, and you can see a couple of things. You see the difference between the baseline group. The baseline group received all of the same trauma therapy, but they did not receive MDMA, they had a placebo. You can see that actually there's an improvement with a 3rd experimental session, and that's why most of the studies, including the one that we're planning at UNM, will have 3 experimental sessions. Here's another way of looking at it, just a graph here, so that in these studies, you're actually seeing 54% of the people with active MDMA no longer meeting the criteria for PTSD. To put this in some perspective, these are not people who've had PTSD for 6 or 12 months. These are people who've had chronic, moderate to severe PTSD. So this is somewhat groundbreaking. So then we have the MDMA phase 3 studies, and there now have been 2 of them. Only one has been published so far. Continue to show pretty much almost identical results. So the primary study endpoint, 18 weeks after the baseline, 67% in the MDMA group no longer met the diagnostic criteria for PTSD. No issues with adverse events or abuse potential, suicidality, or cardiac concerns. And another way of looking at it here is if you look at on the left, you'll see the placebo with therapy and then the MDMA assisted with therapy. And there's different ways to look at it. If you look at how many people are responding, that's the largest number. If you look at people that had loss of diagnosis, that's the darker bar there. Again, it's quite impressive both from session to session and also comparing back to the placebo group. The other thing that's interesting, this is true for really all the psychedelic therapies, is that they seem to be transdiagnostic. So not only was PTSD helped here, but the Sheehan Disability Scale was helped and depression was helped. So all of these outcomes were improved on the phase 3 studies. So here's going to be another video clip here, and this will just be a little 2-minute video clip, and we'll be able to watch several people who've had therapy.
I'm Rachel Hope. I live in West Los Angeles. I was one of the original subjects in the clinical trial in South Carolina testing MDMA assisted psychotherapy to treat PTSD.
My name is Tony Macy. Went to Iraq in 2006 and 2007. When I got back, I was diagnosed with PTSD.
I was diagnosed with acute complex post-traumatic stress disorder, and that's because I had many different kinds of traumatic events that collectively created a really complex and difficult one to resolve. The first 8-hour session I had with MDMA-assisted psychotherapy, I immediately had a reduction of symptoms that was obvious.
A lot of different participants have stated over and over is this is like having 3 years of therapy in one day. And with MDMA, we're really offering a very short-term treatment that requires only taking a medicine 2 or 3 times.
Well, in our first study, people had to have had psychotherapy and medications for PTSD and not been helped adequately. And the average duration of the PTSD in that study was 19 and a half years. And most people had lots of therapy and a number of medicines. Once they got MDMA-assisted therapy, 83% of the people who had not responded to other treatments responded to MDMA versus 25% with the same therapy but without MDMA.
I remember during the therapy, one of the first things I said when it kicked in was, this is what I've been looking for. I reconnected with myself. I did a lot of internal work, and afterwards it was like a huge weight was lifted off my shoulders.
For like 20 years, I was trying to use all these other therapies. I wanted to be free. I wanted to be able to have control over myself. I didn't get any real healing until MDMA. Since the MDMA assisted therapy, even the first session, it was like 75% of all that just went away.
Thank you for sharing these stories, Larry, and giving dimension to what we're learning.
Yeah, I'm trying to give a balance here. I mean, we really, make our decisions in medicine based on studies, but I think it's important to actually hear the human dimension of the story.
100%. Absolutely. Thank you.
So I want to just talk a little bit about models of psychedelic assisted psychotherapy. And one thing I really going to be emphasizing in this talk is that it isn't just these medications. We really think it's a question of how the medications are assisting psychotherapy. As I say, sometimes jokingly, if all you had to do is take MDMA and your trauma and your PTSD all went away, there wouldn't be any trauma or PTSD in England because they have so much being used at raves. But it doesn't work that way. I mean, it really seems that it's important to have the therapeutic envelope. So I'm going to just go over that and discuss what the therapy is like. In general, there's about there'll be a preparatory psychotherapy, about 2 to 4 sessions in each of these studies. The actual medicine sessions varies. The MDMA sessions have been 2 or 3, psilocybin has been 1 or 2, ketamine 3 to 6 sessions, and then integration sessions 1 to 3 days after the psychedelic session. In the time of COVID, those are starting to be done by Zoom, but previously in person. And then psychotherapy sessions occurring after or between the psychedelic sessions. 12 weeks is a common treatment range in each of these studies. So the MDMA therapies, particularly, they're a 2-person team, usually male and female. Where everyone's aware of the fact that that doesn't deal with issues of non-binary and such, but it's been helpful from the point of view of people having trauma relating to a mother or father, also a relationship trauma. I think it's very important to have 2 people at the therapy for numerous reasons. Basically, the goal of the MDMA therapy is very non-directive. The patient brings up the trauma themselves. We don't need to bring it up. It's different than like prolonged exposure or CBT. Simply by taking away the fear that people have been living with from their trauma, that brings them to bring up the therapy. And they've had several sessions of preparation. It's a very safe drug. We do blood pressure monitoring before the first dose and if they get a booster dose. Therapists are trained. It's a manualized training that occurs. That training's been happening throughout the country, and people do need to go through that manualized training. Again, it's supporting the patient's process, goes over how to do the prep, the psychotherapy, and the integrative sessions. Also talks about therapist self-care. This is very intense work. You're with people for 8 hours in a row going over their therapy. So, one of the concerns is to make sure that we care for ourselves as the therapist. So the therapeutic effect is really the interaction between the medicine, the therapeutic setting, and the mindsets of the participants and the therapist. The idea of focusing on empathic presence and listening and letting the patient themselves sort of direct the therapy, somewhat of a Rogerian approach for people who've studied psychotherapy. This is what it looks like. Here you can see the therapist there. You can see the participant there, commonly wearing eye shades and headphones. So how does MDMA work? I'm going to keep talking about this through this. How do these medicines work? What do we think the method is? So if you look at simply from a neurochemical level, increased release of serotonin, dopamine, or adrenaline, activation of the serotonin receptor decreases anxiety and amygdala-related fear response, increases empathy, emotional closeness, compassion, and the effect on the alpha-2 receptors supports psychotherapy, decreasing trauma activation and hypervigilance. So that's on a neurochemical level, how they work. Oxytocin is also involved here, which is interesting for the study we're planning here at UNM, which is going to be with women who've had babies within the last 6 to 12 months. The reduced activation in the amygdala and the insula can be seen on functional MRI, so there's objective evidence there. What we see in the therapy sessions is less fear and anxiety as the memories are processed, and they can be sort of reconsolidated, and really a change can happen in how the memories, which are still there, are viewed by the clients. So one question may come up, is this cost effective? Because this is a lot of therapy here. We're talking about, 42 hours of therapy, 2 therapists, 24 hours of, medication session. So based on the studies that have happened here, it does look that it is cost effective. Almost all the money is actually for the therapist compensation. The medication is not a very big part of it. There's other sort of testing kits there. If you look at, if you follow out for 30 years for a cohort of 1,000 patients, you'll avert 40 deaths, massive decrease $100 million in combined mental costs. And that, although we obviously haven't followed anyone for 30 years, the MDMA therapy comes out being cost effective unless it's assumed that benefits cease after 1 year, which there's no reason to be expected that. So the MDMA therapy breaks even in cost at 3 years. Another way of looking at this is when you compare it to other treatments. Unfortunately, we don't really have very good other medication treatments. SSRIs are common. One thing that we've seen is the dropout rates for the SSRIs here are much higher than for the MDMA. On the right, you'll see the MDMA at 7%, and the Paxil at about 30%, and Zoloft close to 30%. So one of the real issues is that people actually getting through the therapy for the SSRIs. So might MDMA be useful to treat addictions? That's what this talk is about here. So I think when you think about that, you want to think about how we could treat addictions. So one could be by treating the PTSD itself. I mentioned, that there's a strong association between PTSD and addiction. So simply by treating the PTSD, that may be the way of treating addictions. It might also happen by the same mechanism as classic psychedelics, such as psilocybin. What are those mechanisms? So what I'm going to do here is I'm going to take a little break here from MDMA, talk about some of the psilocybin mechanisms. Again, MDMA is sort of a medicine that's sort of in between a stimulant and a classic hallucinogen. So there may be the same way that psilocybin works may also help MDMA. So psilocybin addiction, active ingredient in psilocybin-containing mushrooms metabolizes psilocin inside the human body. I have this picture of Maria Sabina because I think it's really important as we're looking at this that these are new to us. These are not new medicines. These have been used by indigenous peoples. They continue to be used by indigenous peoples throughout the North and South America. And it's important that we give acknowledgement there. And hopefully, that as we're as these medicines become more available, the idea of indigenous reciprocity and making sure that indigenous peoples have ideally more access than other peoples, but certainly at least about the same amount of access. So psilocybin has been studied for a lot of things here: treatment-resistant depression, depression and anxiety with cancer, addiction, tobacco, alcohol, and opioids. Psilocybin and classic psychedelics, similar effects to LSD and mescaline. One reason why psilocybin is being studied is it's shorter acting, which is easier to study. It also doesn't have the cultural baggage of LSD, which reminds people of the 1960s and the counterculture. So how does psilocybin work? Bound to serotonin receptors here. How does that work in the level of the mind? What it does is it has an effect on the default mode network, and it allows there to be less top-down influence over the brain and increases the connectivity between different parts of the brain is how it's hypothesized to work. Partially this is based on functional MRI, partially it's based on psychological studies. And here, if you look on the left and then the right, clearly seen in this picture, you'll see the idea of more connections. And I'm going to talk about the whole idea of connectedness as well. That's actually felt to be a potential psychological mechanism as well as a neurochemical mechanism. So again, the decreasing activity in the default mode network, how might that work? It's hypothesized to decrease rumination, obsessive thoughts, focus on autobiographical content that's common in severe depression, common in OCD, common in anxiety. So there's by working in these ways, these drugs have the potential to work with multiple diagnoses, which is interesting as we look at studying, because we know that there's significant rates of certainly PTSD and addiction, depression and addiction that overlap. Psilocybin and tobacco cessation. So the initial study, this was done at Johns Hopkins, very small numbers, but actually fairly amazing results. As most of us know, it's very, very hard for anyone to become abstinent. These people had been had been smoking average 19 cigarettes for 31 years. So on this follow-up at 12 months, 10 of the participants were biologically confirmed as smoking abstinent. At 6 months, 12 of the 15 were abstinent for at least 7 days. So these are very impressive. And as I think the next slide, so this has led NIDA to fund a multi-center trial at 3 different centers looking at tobacco: Hopkins, Alabama, and NYU. I want to talk a little bit because this is a study done here at UNM. I'm not sure if Dr. Bott's in the audience, but a big shout out to Dr. Bott, who is a leading person at UNM doing this study. Dr. Michael Bogenschutz, who formerly was at UNM and now NYU is the principal investigator. So I'm going to show you another video here, and this is from someone from the alcohol study done at the University of New Mexico.
I drank a lot, and I drank every night after the kids went to bed, just to drink wine, beer, vodka, hard liquor. It just grew to become something that really wasn't me, but it just became a habit. I really did not see myself quitting drinking anytime soon because I didn't think that it was affecting my life. Kids went to bed. I wasn't realizing just how much it was influencing and taking kind of a control of my life. I mean, it really was. It was sad, you know, it was sad to think, wow, and for what? For what? What am I doing this for? Alcohol every day, everywhere. It just was part of my life. I didn't even know what to expect. I just was kind of like, hey, you know, no big deal. I'm easy. I could do this. I had no expectation. And Michael didn't really even lead me into one. He just said, you know, things may happen, just go with it.
Having a little trouble getting the video part here. I think you're hearing that. I'm going to try to see if I can fix the video for us here.
It was torturous, actually. It hurt emotionally and physically. I needed to acknowledge the hurts that I had personally, and I had to acknowledge the hurts that I had done others. And I wasn't even thinking, why do I drink through all of this? This had nothing to do with it. It just had to do with my lack of gratitude I felt. And I was sad with myself, and I was ashamed of myself. I used to like me, and I stopped. And then I had to say to the older Sarah, that's okay not to like yourself. Like, admit it, and it's okay because you want to change. I went from that point to becoming a mother of my children, my beautiful children. And I thought of all the times that I just was not present with them. I was there. I mean, I do a lot with my kids, but I was not really there like I should be, like I wanted to be. And that was hard to accept. But I was so grateful that they're little and I have time. And I had seen the light of that, you know, I had seen the difference. Through part of the session, I couldn't see my kids' faces. It was as if I had to work through things, you know, kind of wade through all these different dark emotions. And then I saw them, and I was like, the experience was emotion. I don't think I stopped crying from the time I started the session to the time I ended. Tears just flowed. Had it been a movie, it's a sad, depressing movie, but you don't want to stop watching it, you know? It was sad because I'd gotten so far away from where my true self really should be. And I was alone, and I had taken myself there. That was the sick part, you know? It was all, I did this all to myself. I had to accept and move on. And I did, because I never wanted to stray as far away as I had from who I really am and what I really believe. That first experience was painful. I mean, I felt physical pain, raw, guttural, sobbing emotion. And it really was my life. You know, it wasn't like I was in some, fantasy. This was my life. And as hard as it was then, I'm so grateful for it. I needed to see that. The second session almost felt more like a reward for my hard work. That experience was bright and light and hope. I had those 4 weeks to really kind of process what had happened to me in the first session. 10 years of therapy and, a 3-hour period. When the second session came into swing, my world was just this peaceful, babbling brook.
I'll make sure that you have a link if people want to watch the
Yeah, that would be great.
that whole video.
Powerful, very powerful. Yeah.
Yeah, I want to make sure we have enough time to talk about everything. So let me go back to screen sharing here. So this is a really important study. This came out in JAMA Psychiatry just about a month ago. This is one that was done at UNM. This was a randomized, trial looking at psilocybin versus Benadryl and showing the primary outcome of a decrease in heavy drinking days. And it showed that. It shows statistically significant. I'll show you a diagram here where you can see, so you can look here comparing the two treatments, psilocybin versus diphenhydramine. Again, if you look at it in the bar, you can see there's more than a 50% decrease in the heavy drinking days. So this was felt to be very significant. I certainly would agree. And this is going to be a multi-center trial starting with UNM. That's going to be one of these sites next year. One thing that is interesting is that this is not totally new. I mean, if you go back, there was research done, although the quality was not up to modern rates of LSD and alcoholism back in the 1960s to 70s. There's actually just a little bit of a detour, but it's kind of a little bit interesting for a lot of us. I think most of us are familiar with 12 steps and AA. Well, the head of AA actually, when he actually quit drinking, he was actually hospitalized and got something that then was called the belladonna cure. Belladonna is actually an extremely toxic hallucinogen. Nobody's recommending belladonna now. We're not studying that, but it's interesting. It kind of fits in with the vision that Wilson had, which was a chain of drunks all around the world helping each other recover. This was really the foundation of his sobriety and his belief that a spiritual experience is essential to getting sober. What's also interesting is that, based on that, he actually used LSD under federal research during the time, and he was very enthusiastic about it. He felt like it could be a great benefit for alcoholics. And as Stephen, Ross, talks about, there's the problem back then is AA really was not receptive to psychedelics back and then, as he says somewhat facetiously, but sort of true, the attitude that all drugs are bad except you can have as many cigarettes and as much caffeine, as many donuts as you want. So hopefully we're at a better point right now, and that, the hope is that as psychedelic therapies are researched, that we can work with the very important 12-step programs so that they'll be supportive, when these therapies, if they're shown benefit. There's actually a group called Psychedelics in Recovery, which is a 12-step program, which is a fellowship of people who are actually been using psychedelic or plant medicines. These are sprouted up around the country, so you may be familiar with them. I think it's something that may be helpful as we do more and more research, so that people have those type of groups to be working with. So let's shoot back to MDMA. As you may hopefully recall, I was looking at the way that MDMA may work for substance use, may be similar to psilocybin, and maybe through PTSD. There's only been one study so far in the US, or in the world actually, about using MDMA for substance use. That was in England, and that was looking at it just with 10 patients for alcoholism. Again, the studies, very small numbers, but looks promising. So what we're excited about here is thinking about how we can study here for opioid use disorder and PTSD combined. I want to talk about one thing too, like how is, I mean, some of you may be going, how can actually a drug work on multiple illnesses? How might that work? Some of the theory behind this is that it's working on things that are common, which is sort of obsessive thoughts, compulsions, ruminations, kind of stuckness, and that by working on those, which are a common factor in mental illness, that may be why we can actually be able to help for many, many different mental illnesses. The other ways when you look at the mechanism of change is to think of like the idea of pivotal mental states here. In the studies that are that have been done, one thing that we see with psychedelics is they often produce a challenging experience, sometimes a mystical state or other pivotal experience. I want to try to describe that with some animations here to talk about how that may work. So here we have somebody going down going down a little ship here. They're in a river and they have different ways that they can go. They have, as they're processing, one may be a path towards healing. The other may be taking them a path that's sort of unwell. Sometimes that may be causing a challenging experience. In the vernacular in the past, people used a bad trip. We don't use that terminology anymore. We talk about challenging experiences. And the reason why we don't use that terminology is that the challenging experiences may be part of the healing. So one question is, how do you reach the pivotal state? How does one choose which stream to follow? With a poor set or setting or lack of preparation, one can head down the wrong stream. That's why in all these studies that are being done, there's a big effort to have a safe setting with therapists and integration sort of help people that when they do have challenging experiences, they can come out on the healthy side. So here we have the person still sitting in the boat there. Another way to look at it is to look retrospectively. So this is not a prospective study. This is a study of 2,000 people who had psilocybin experiences outside of a clinical trial. 1 out of 3 reported this is one of the most challenging life experiences. So these can be hard experiences. That's why we're really trying to make the point. We're not recommending people are taking these recreationally to help their addiction or their depression, but it's really in the setting of therapy that can be a safer. The good thing is that even in the people who did this outside of therapy, eventually 84% reported, positive gains, but it can be a very rocky road, and that's why we're emphasizing the importance of integration therapy. So I'm going to talk a little bit about our UNM MAP study here. We're really excited about this here. This recently got FDA approval for doing this, and hopefully we'll be getting this going within the next year. It's an open label feasibility study, postpartum women 6 to 12 months after birth, women with opioid use disorder, buprenorphine or methadone, and moderate or severe PTSD. We're using the same MAPS protocol that's been used for PTSD, but in addition to PTSD, we're going to be looking at opioid use disorder as a secondary outcome, comparing use in the 30 days prior to assessments for 6 months afterwards. We're also in this study going to look at other things. We're going to look at how does this actually affect parenting? How does this affect maternal infant bonding and attachment? We know that there are intergenerational effects of trauma. We know that there's intergenerational effects of addiction itself. We know that some of this may be from epigenetic transmission, others from adverse childhood experiences. The hope is that the MDMA therapy, if it helps with the PTSD, may be able to, in addition to helping with the PTSD and the opioid use disorder, help with the maternal infant bonding, help with the intergenerational transmission. So we're going to study maternal infant bonding scales, parenting sense of competence, and qualitative semi-structured interviews. So to talk a little bit again about how do we think that the MDMA work, we're going to look at mechanisms of change. So we have questionnaires looking at mystical experiences, emotional breakthroughs, challenging experiences. And I think it's really important to be doing this as we study things so we can try to get an idea, is there a way that we want the therapy to support things that may bring people towards the type of experiences that are more likely going to produce positive behavioral changes. the other way that we're looking at this, a lot of us think that addiction itself is sort of the opposite of connectedness. People tend to get into a narrow existence where the only thing they're focused on is getting their drugs. So we're actually including exploratory outcomes of connectedness. There's several scales that have been doing this, that looks at a person's subjective connection to society and humanity, self-perceived emotional distance, and a scale that was developed called the Watts Connectedness Scale, which is expressly developed to look at outcomes of psychedelic studies. So those are all going to be exploratory outcomes. Some people may be wondering, well, how do you get these studies going here at this point in time? So this is an investigator-initiated trial that I started. So from July to December 2020, I designed the study. MAPS reviewed and approved it as July 20 to 21. For the next year, it went through several revisions with the FDA. And we're very excited to say that on July 6th, the FDA gave us approval. We're now working with the UNM IRB for approval here. After that, it's the DEA will need to review that, and then we'll need to get a Schedule I DEA license. One of the discussions at the NIH conference is the hope that this can be streamlined so it won't take years to get this. So I want to mention a little bit about methodological challenges in studies of psychedelic compounds. This is relevant for what I'm talking about, addiction, but it's also relevant for studies of other things, whether it's studying psychedelics for pain or for depression. It's really hard to blind to an intense psychedelic experience. 90% of participants in most studies or more are able to identify which group that they're in. And we may need to look at different other research paradigms. We're trying different things using active controls such as Benadryl or Ritalin. I think is the therapist's enthusiasm and high level of skill. So this should be balanced in the study because it's the same therapist doing the placebo and the non-placebo, but is this training scalable to reach enough therapists and patients? Large numbers of therapy need for 2 therapists. So these are going to be important things to look at because we want to make sure if these compounds are felt to be beneficial that people have access. Role of expectations is important here. One has to be careful so you have a group that realize they haven't gotten the therapy, that can have sort of a negative effect. And one way of dealing with that in the studies is to allow the group that gets placebo to later, after the study has been unblinded, to be able to receive the active treatment. Training therapists, what background is needed? The MAPS MDMA training is about 100 hours. How do we train residents? I was talking recently to a psych resident who really wants to get trained, but this is hard to integrate into a residency because you need to have the same therapists available. So it's something that we're all looking at, is how to get training both for current therapists and for people who are training during their career. Another question is, what forms of psychotherapy work best with MDMA or classic psychedelics? There's a variety of these that we're interested in looking at. This acceptance commitment therapy is a form of cognitive therapy. It tends to promote psychological flexibility, adherence to goals, and so we think this may be very useful for addiction. Motivational enhancement therapy is what's used in the psilocybin and alcohol studies. There's also been psychedelic-specific training, looking at somatic approaches, internal family systems. It looks at different sort of parts of the mind, and also Jungian approaches and non-drug experiences in non-ordinary states of consciousness, such as holotropic breath work, may be helpful both for participants but also for therapists. So questions for further MDMA and PTSD research, expanded indications, how much therapy, how many medication sessions, which psychological factors, what are contraindications. So I'm hoping that we'll have answers to all of these in a few years, and maybe we'll have a follow-up conference here and have some information to share with people. I think I still have 5 minutes. I mean, if that's okay, I'm going to talk a little bit about ketamine. Ketamine is very different than the other psychedelics. It's actually, generally has been often viewed as primarily as an anesthetic agent. It's actually a very safe anesthetic agent. It's actually a WHO essential drug. What's been happening recently, it's being used in studies for treatment-resistant depression. There's also been a series of studies that have been done looking at ketamine for opioid use disorder and stimulant use disorder. there's different clinical models. The infusion center is separated from a therapy. I'm actually for addiction, particularly interested in ketamine-assisted psychotherapy. I think that although we need to actually study whether the therapy has a role, I think it's highly likely, given what we know about addiction, that using both the medicine and therapy will be beneficial. I'm going to skip through these here. So one thing we have a study that we're actually sent out for grant funding and we should hear about, but is looking at it for polysubstance abuse, opioid use disorder, and methamphetamine. One is trying to blend a ketamine-assisted therapy. The other thing about ketamine, it's very different than MDMA and psilocybin in that it has different effects at different doses. One interesting idea with ketamine is to use the lower dose, which has been called psycholytic. People can talk during that, and it may be really good for processing trauma. And then following up with higher dose therapies that may produce some of those mystical experiences, the breakthrough experiences. So in the study that's we have that's still out for consideration, NIH, we'd like to combine both of those. And I'm going to skip that here. So good news, increasing support for psychedelic therapies from NIH, Congress Executive Branch. This is a May 2022 letter that came out from Secretary of Mental Health and Substance Use. There was a recent hearing, congressional hearing, where Dr. Nora Volkow, who's the director of National Institute of Drug Abuse, presented there and was very enthusiastic about trying to increase research, really feeling like these are potential breakthroughs for addiction. I just want to thank everybody for a lot of the background for this talk. I was able to do a therapy that was supported by the School of Medicine and the Family Community Medicine and the University of Wisconsin. Dr. Bott and I have been collaborating. Thank him, and just a lot of other sort of trainings that are happening, and the Indigenous elders who've shared wisdom in the use of these therapies.